So last but not least, we will have our last speaker, who is Dr. Richard Baltero. He's an MD, PhD, pathologist with over 5 years of experience in medical and scientific leadership and in laboratory medicine. He is a certified anatomic clinical pathologist, subspecialized in immunopathology by the ABP. He is a fellow of the National Academy of Clinical Chemists, and he was born originally in Caracas, Venezuela. He received his PhD in molecular microbiology at the University of Rome, La Sapienza, and his MD from the Catholic University of the Sacred Heart, Università Cattolica del Sacro Cuore. I hope that you guys got my Italian right. In Rome, Italy. He did his training in APCP at Brown University, completed a fellowship in clinical pathology at George Washington University, and immunology at the NIH. Dr. Baltero is a commissioner of the Laboratory Accreditation of the CAP for North Carolina and deputy commissioner in the Inter-Region, now serving as the Inspection Process Committee and previously Scientific Committee of Chemistry, Diagnostic Immunology, and Flow Cytometry Committee. He's been a laboratory inspector for almost 40 years. He's an active member of the AACC, American Association of Clinical Chemists. He's on multiple divisions of the History of Chemistry Division, Clinical Diagnostic Immunology Division, and was on the CME Advisory Committee, Judge Stoddard Poster Competition and oral presentations for many years of the same. And he's also a trustee of the History Pathology Society, as well as Dr. Loeffler. And he is now at East Carolina University as a professor of pathology and laboratory medicine. And before that, he used to be at Creighton University, University of Rochester, Oklahoma, and Marshall University. So welcome, Dr. Baltero, and thank you. And thank you all for your patience and staying until the end.
I have no conflicts of interest and no disclosures. Genetic testing is, in clinical practice of hematology, extremely important. Not only confirms diagnosis, assesses effectiveness of therapy, predicts prognosis, monitors for specific chromosome abnormalities, and assess the bone marrow, especially in transplant. I will start the story on July 24th, 1900. On that day, Carl Correns received a paper and a letter from Hugo de Vries, who was the most famous botanist at the time. And Hugo de Vries is famous for inventing the word gene. It originally was pangene, but then it was dropped, it was gene. And what the three botanists had discovered were the laws of genetics. And de Vries wanted to take full credit. So the day that he got the letter, Correns immediately wrote his paper, and his paper I gave you as the reference in German, but there are English translations, and he entitled his paper, G. Mendel, the laws of the behavior of the progeny of variants hybrids. And he gave credit to Mendel, and if you know Mendel, it's because of Correns. And of course, he said, oh, by the way, I got the same numbers and results as de Vries, and the third guy did the same. And finally, a year later, in 1901, an American also did the same. So shortly before, the Fleming had discovered and illustrated chromosomes. He called the word mitosis. Bond and Wildenmeyer, a German anatomist, had named the filaments in the nucleus as chromosomes, and Bateson, which was an American, had given us the word genetics. But it wasn't until Morgan that he did this work on the fruit flies that a lot of things became clearer and clearer, and they gave him the Nobel Prize. So in 1923, it was believed, and it was published, that the correct number of chromosomes was 48, and Painter had given us the X and the Y chromosome terminology. In 1953, after some of us were already alive, Watson and Crick described the double helix, the DNA. And by the way, we should give credit to the lady, Franklin Rosalind, but she died. And you should be alive at the time when the Nobel Prize Committee gives the prize. Tito and Levan finally, in 1955, figured out the correct number of chromosomes in humans is 46, not 48. And then the first aberrant chromosome was described by the Frenchman Jérôme Lejeune in 1959 as the extra chromosome 21 in Down syndrome. In 1960, the Philadelphia chromosome was discovered in Philadelphia and the University of Pennsylvania. And to this day, conventional cytogenetics is the most frequently ordered genetic test for various leukemias, especially chronic myelocytic leukemia. So the benefit of cytogenetics is that it's a screening test. So the banding here is a modern banding. It's not the original banding because at the beginning was even more fuzzy and more difficult to see. But this, as you can see, there is a 922 translocation where the 9th chromosome is a little bit longer and the 22 is a little bit shorter. Not easy to see early on, but in 1968, Kasperson in Stockholm at Karolinska found that you could band DNA. And after that, there was a cascade of developments in cytogenetics. And within the last 3 decades, you might say 4, we have this other technique, which is fluorescence in cytohybridization, which has increased greatly the resolution and the application of traditional genetics. Now, FISH does not require mitotic cells. A large number of cells can be scored, enables analysis of different cell types, bone marrow, blood, cells of various origin, is usually straightforward, rapid in interpretation, and is very sensitive. It detects very minor changes that cannot be observed with the conventional cytogenetics. And we've all seen these kinds of images when you have these green and red and intermediate red, yellow, and green. And you can even band various chromosomes different colors. So in CML, we now know that there is a CML breakpoint, and there's a 922 translocation. And actually, not all the breakpoints are in the same location. But if you're going to have CML, you have to have 922 translocation. By the way, some cases of are where they have a 922 translocation in a different place are not CML, are ALL. So we now have cytogenetic abnormalities in all kinds of hematological diseases, and I think you cannot really do justice to patients if you don't do additional, not just flow cytometry, but cytogenetics and molecular in any malignancy. So we now need them for not just chronic myeloproliferative diseases, myelodysplastic diseases, acute myeloid leukemias, and B and T cell diseases, as well as lymphomas. So 95% of the time, you will have a translocation between 922, which is seen in by cytogenetics. But in the other 5 to 10% of the cases, there are less apparent mutations. But if you do special studies, you will find them. And as I said, not all the translocations in 922 are just in CML, but there's also in ANL, L, and ALL. And here is a beautiful fish that shows you the dual fusion of 922. And I'm going a little bit fast because of time constraints, so we want to give a chance to give some questions. So a discovery in 1980. Now, I don't know whether ancient actually is the correct terminology for these things, but I thought that was cute. They discovered translocation between 15 and 17 in this microgranular variant, which had just been described 3 years earlier. And this has become extremely important because especially after 1992 with the all-trans retinoic acid therapy and with the 1997 with the arsenic trioxide therapy, you can actually change completely the life of these individuals. This is just to show you that hematology of bundles of hard rod in the microgranular variant. This is a treatment is an emergency. Diagnosis is an emergency. If you do not make the diagnosis, very high percentage of these patients will die of cerebral hemorrhage. And even with the correct diagnosis, we still may lose 15 to 20% of the patients. So you need to make the right diagnosis and then start treating with retinoic acid or the other more complex therapies, and they're relatively benign. You have remission, something like 80 to 90% of the cases, and people have survival to 3 years of 70%. Here is a translocation between 15 and 17. The errors are relatively small under 15 and 17. And here is one of our fish, which is the other beauty of fish is you can do it quickly. You don't need to wait like cytogenetics until they grow. So here's a case that I had about 20-some years ago, more than 20 years ago, when these therapies first came out. And this lady was a resident at the time. She's now a hematopathologist, was one of my residents. And so we had a relatively healthy 24-year-old lady, and she had a relatively short history of fatigue and bruising. You can see the peripheral there. This is the peripheral, and she was full of blasts. And this is what the bone marrow looked like. And so pre-treatment, the reason why there's only 20 abnormal cytogenetic cells is because you're required to measure 20. Cap requirement is 20, but you can measure more than 20. Okay, but she had way more than 20. But that's what that. And by fish, 75% of the cells had a translocation, and by fish it was hypercellular. And you saw already the bone marrow. 15 days after treatment, she had no abnormal cells by cytogenetics, and 75% of the cells did show fish translocation. So fish is more sensitive in this case than cytogenetics. And the bone marrow was already a little bit hypocellular, and by fish it was hypocellular. 60 days post-treatment, she had no abnormal cells, nothing by fish, and she was hypercellular. And as far as I know, this lady is still alive and well in Omaha, Nebraska. One of the additional tests, syndromes that was discovered was the 5q minus, which was a myelodysplastic syndrome in 1983. This was described, and this has a much better prognosis than several others. The most common abnormality in CLL is chromosome 12, an extra chromosome 12, and you basically have a bad disease. Your prognosis is shorter. One of the additional few things I'm going to describe, and this is going to be the last thing I want to describe. This paper was from 1949, and the first author was Linus Pauling, who got Nobel Prize, not for this. He also got another Nobel Prize because he was a peace activist during the Vietnam War. And he described his group in California, in Pasadena, they came up to the conclusion that the sickle hemoglobin was producing a different amino acid than the normal amino acid. And because of this, this was a molecular disease. And I am going to close with, 1956, they finally found, they described the 1-point mutation in sickle cell. But in 2014, gene therapy for sickle cell in human was started. They started the phase 1 with the lentivirus. In 1917, the first successfully treated patient was published. And this is what happened in 19. They started doing CRISPR, editing the bone marrow from a person, first by boosting fetal hemoglobin. And in November of 2023, it was approved. CRISPR was approved in the United Kingdom, not just for sickle cell, but for transfusion-dependent beta thalassemia. And last December, in the United States, the FDA approved the first CRISPR gene editing treatment for sickle cell. I'm sorry that I went a little bit fast, but we wanted to finish on time. And the bad news, this is one of the very first patients. She's a lady from Mississippi. And the bad news is that we're talking $1 million for just the treatment. Not the treatment. This is just the pharmaceutical. Okay? And the rest of the treatment costs another $1 million, plus or minus. So as you can see, that is not very affordable, but at least it's a step forward. Thank you very much. Sorry that I hurried.
Thank you so much, Dr. Baltero, for your review, and I appreciate the speakers for helping us with the time constraints. So with this, I mean, we basically have finished our companion meeting. I appreciate all of you guys who have stayed until now, and I really want to thank the speakers again for all their fantastic presentations and work done today. And just some final announcements. This will be my completion of the period as a president, Histopathology Society. The role now, the label will go for Dr. Rafaela Santi, who is right here from the Universidad de Firenze or Florence. So she will be in charge next year of managing and preparing all the companion meeting and just some. Hit the cable now. So start and then finish. Thank you very much, everybody. The meeting is adjourned.